I'm Ivy, and welcome to Healthiest US Beta Blockers Post-MI. A clear clinical message: the reboot and BETAMI. DAN block trials on beta blockers post-myocardial infarction (MI), presented at the European Society of Cardiology Congress this weekend, appear to yield different results. While technically true, practically I believe they tell the same story. First the trials, and then why I think the translation of these new data is easy. Reboots in Spain and Italy. Reboot trialists randomly assigned slightly more than 4,200 patients after an MI to receive beta blockers, mostly bisoprolol, or not receive beta blockers. Their median age was 61 years, 19% were female, mean left ventricular ejection fraction (LVEF) was 57%, and about half had ST elevation MI. About 12% of patients had an LVEF between 40% to 49%. More than 90% underwent coronary stenting. After 3.7 years, a primary outcome event of death, MI, or hospitalization for heart failure occurred at a rate of 22.5 per 1,000 patient years in the beta blocker arm versus 21.7 per 1,000 patient years in the no beta blocker arm. The hazard ratio, HR, was 1.04, 95% CI, 0.89 to 1.22, p equals 63. There were also no significant differences in any of the components of the composite endpoints. Reboot clearly showed no signal of benefit for post-MI beta blockers. BETAMI. DAN block. In the merged BETAMI DAN block trial, Norwegian and Danish investigators randomly assigned 5,574 patients after an MI to a beta blocker, mostly metoprolol XL, or none. Their median age was 63 years, 21% were female, and 16% had an LVEF between 40% to 49%. More than 92% underwent coronary stenting. After 3.5 years, a primary outcome event of death or major adverse cardiac event, including MI, unplanned coronary revascularization, ischemic stroke, heart failure, or malignant ventricular arrhythmia, occurred in 14.2% of the beta blocker arm versus 16.3% in the no beta blocker arm. The 2.1% absolute risk reduction translated to a statistically significant 15% relative risk reduction. HR, 0.85. 95% CI, 0.75 to 0.98. P equals 0.03. The driver of this composite endpoint was a 1.7% absolute risk reduction in reinfarction. HR, 0.73. 95% CI, 0.59 to 0.92. All other components of the primary endpoint, including death, were very similar in the two groups. BETAMI. DAN block was a positive trial, albeit with a small effect size in a non-fatal outcome. Meta-analysis of patients with mildly reduced EF. Authors of these ESC trials and the smaller RCT trial shared patient-level data to study outcomes in patients with an LVEF of 40% to 49%. Individually, none of the trials had the power to assess signal in this subgroup. In total, the meta-analysis had 1,885 patients with mildly reduced LVEF. The agreed-upon composite primary outcome was death, MI, or heart failure. In the beta blocker arm, the rate of the primary outcome was 32.6 per 1,000 patient years versus 43 per 1,000 patient years in the no beta blocker arm. The relative risk reduction was a statistically significant 25%. HR, 0.75. 95% CI, 0.58 to 0.97. P equals 0.03. All trials were directionally consistent. Each component of the primary outcome was lower in the beta blocker arm, but none reached statistical significance. For context, the difference was 19 fewer patients, 106 versus 125, who had an event in the beta blocker group. Post hoc study on beta blocker withholding in Rebooterbut authors also published a post hoc study exploring outcomes in the 12% of patients who were on a beta blocker before the trial and then randomized to no beta blocker. Patients on a beta blocker were older and had more comorbidities. Yet there was no difference in outcomes in this subgroup. Importantly, in patients taking beta blockers before their MI, randomization to no beta blocker withdrawal was not associated with an increase in ischemic events. Merging trials with REDUCE-AMI. Last year's REDUCE-AMI pragmatic trial of beta blocker versus no beta blocker in patients with an MI and LVEF greater than 50% found no statistically significant difference in a primary outcome of death or MI. Dan Atter, the senior author of BATAMI, told me at the Congress that a meta-analysis of the nearly 10,000 patients we learned about this weekend with the 5,000 in REDUCE-AMI is planned. Comments and clinical translation. My proposal is that we have enough evidence now to change our practice of mandating beta blocker use in all patients after MI. I've always felt that this mandate had weak evidence. The external validity of the pre-reperfusion positive BOT and ISIS-1 trials is quite low. Did you know that in BOT, propranolol was started on hospital day 9? Taken together, about 15,000 patients have been randomly assigned to beta blocker or not in the setting of modern MI therapeutics, including, most importantly, urgent revascularization. The outcomes are largely similar. Reboot, RCT and REDUCE-AMI all found no signal of benefit. BATAMI, Dan Block finds a small reduction in non-fatal reinfarction, about 2% ARR, but no differences in death, CV death, or other outcomes. When meta-analyzed together, I am confident that the null signals from the 3 trials will outweigh the small signal in the 1 trial. The clinical implications of these trials are major because they decrease the work of being a post-MI patient. When a person has an MI, it is a signal that heart disease is a threat. You want them to spend their limited attention and energy on maximally beneficial preventive measures. Eliminating a drug, beta blocker, that can have side effects allows them to spend more of this limited attention on things like diet and exercise, along with lipid-lowering therapy. A caveat is that many patients screened for these trials were not enrolled because they had a separate indication for beta blockade. This evidence, therefore, does not mean we always avoid beta blockers after MI. Mildly reduced EF meta-analysis. 4 reasons for caution. What about the mildly reduced EF subgroup? First, the absolute differences were small. In nearly 1,900 patients, only 23 fewer patients had a primary outcome event in the beta blocker arm. None of the individual outcomes had statistically significant signals. The differences in both death and MI were less than 0.5%. Second, this small effect size barely met statistical significance. The upper bound of the 95% CI was 0.97 and the p-value was close to our threshold. Individually, each trial enrolled approximately 3 times as many patients as the meta-analysis of the mildly reduced EF subgroup. It's quite possible that the effect seen in the meta-analysis is noise rather than signal. Third, the premise that cardiologists are precise enough echo readers to distinguish differences of 51% versus 45% in ejection fraction is utter folly. What's more, an LVEF of 40% after an MI could easily rise to 50% within a month. I strongly urge key opinion leaders to heed the overall trial results rather than parsing subgroup findings. Fourth, the prior evidence of beta blocker benefit in this group is widely overinterpreted. The seminal Capricorn trial of patients with MI and reduced LVEF randomly assigned to carvedilol or placebo actually had a non-significant primary outcome of all-cause death or cardiovascular hospitalization. Many consider this a positive trial due to lower rates of all-cause death. I and others disagree because the individual outcomes were underpowered. Summary: the totality of evidence clearly supports a reversal in practice. There may be reasons to use beta blockers in selected patients with MI. But the mandates and quality measures for routine use of post-MI beta blockers should end tomorrow. The meta-lesson of these strong trials is that our established therapies require expiration dates. As practice changes, we should be open to challenging established beliefs. Few better examples exist in medicine than the post-MI beta blocker story. John Mandrola practices cardiac electrophysiology in Louisville, Kentucky, and is a writer and podcaster for Medscape. He espouses a conservative approach to medical practice. He participates in clinical research and writes often about the state of medical evidence. Thank you for watching.